Module 8 is about cardiovascular disorders and is following chapter 12 in your book. So a quick review of the heart anatomy and physiology. Basically, the way that blood moves through the heart, through the different chambers, valves, and vessels. So if we are talking about the right atrium is right here, and it is going to collect deoxygenated blood from the body from the superior vena cava and the inferior vena cava. So as you probably already know, it's blue on these diagrams because it's deoxygenated. Then we have the right ventricle, and the right ventricle is going to pump blood, deoxygenated blood, to the lungs. So it's going to pump up through into the pulmonary artery to the lungs, where the lungs will oxygenate the blood. On the way back from the lungs, going on the pulmonary veins, these little red guys over here, the oxygenated blood is then going to be collected into the left atrium coming from the lungs. Next, we're going to go into the left ventricle, where the left ventricle is going to pump the oxygenated blood through the aorta and to the body. Then when we're talking about the heart valves, so we have two different main types, the AV valves that are between the atria and the ventricles, and also the semilunar valves, which are the pulmonic and the aortic valves. So the two AV valves are the tricuspid on the right side, and then the mitral, or also called the bicuspid, on the left side of the heart. Then the other vessels, I already pretty much went over them when I was talking about the blood flow at the heart, but you can read this bottom part yourself. So if we're talking about fetal circulation, we're talking about blood flow through a fetus when they are in the womb. So when we are a fetus, 90% of our blood is actually going to bypass our lungs. This is because the placenta is the organ of respiration. So we don't need the lungs to basically be our organ of respiration while we're in the womb. We only need a small amount of blood to go to the lungs to allow the lungs to grow and develop properly. Otherwise, we have some special structures that help blood bypass the lungs. So one of these structures is the ductus arteriosus. So the ductus arteriosus is the special pathway that allows blood to flow in different ways away from the lung. So it can basically bypass the lung. We also have the foramen ovale, which is basically a little hole in the heart in between the two atria that has the same exact function. It just allows blood to basically bypass even going up this pulmonary artery. So it's just going to bypass and go over here into the left atria instead. So again, just another route for blood to go to bypass the lungs. Another one that's not necessarily typed out on your slide, but it's down here, the ductus venosus. Similar function. It's a separate pathway that allows blood to bypass the liver because we're not necessarily using our liver to filter our blood when we're in the womb. We're using the placenta. So we have oxygenated blood that comes up the placenta and up from the placenta into the inferior vena cava and is basically flowing into the right atrium. We also have deoxygenated blood coming from the superior vena cava into the right atrium. So a lot of mixing of blood of high, medium, and low oxygenation status. After birth, these structures will close within a couple days to a couple weeks. So meaning the ductus arteriosus, the foramen ovale, and the ductus venosus, those will close fairly quickly after birth. We're going to talk about a couple of situations where they do not close. So if we are assessing a child that we suspect has a cardiovascular problem or a history of a cardiovascular disorder, we can take a general history, things like a family history, any genetic disorders that run in the family, as we've talked about before, some genetic disorders can also have congenital heart abnormalities that go along with it. We can ask about prenatal history and gestational age. There's a couple of disorders we're going to talk about that affect premature infants. Any exposure to infections or teratogens during the pregnancy. Any problems with feeding, weight gain, or milestones, and any pain. So pain, when we're talking about pain for cardiovascular assessment for a child, chest pain is a pretty rare symptom in a pediatric client. There are a couple of exceptions like Kawasaki disease, and they can have chest pain from other things like costochondritis or other musculoskeletal conditions. But actual chest pain, like cardiac pain, is actually pretty rare. So on physical examination, we can do things, of course, like height and weight to see if their failure to thrive. Were they small for gestational age at birth? Did they have poor weight gain as a baby or a young child? Do they have any dysmorphic features that we would think possibly they have some sort of genetic disorder? Any chest wall deformities or any developmental disabilities? We can also look for things that we're pretty familiar with, like clubbing, redness in the fingers and toes, any respiratory distress, especially when they're feeding or crying. What's their level of consciousness? What's their cap refill, pulses, edema, and what is their blood pressure? This is one instance where if we suspected or have a known cardiac disorder in an infant, where we would do a blood pressure. Of course, looking for things like cyanosis, doing pulse oximetry. What does their skin look like? Is it pale and mottled? Do we hear a murmur or any shifting of heart sounds? Some diagnostic tests we could do is a chest x-ray. You can see certain things on a chest x-ray, like if the heart is enlarged. We can do an arterial blood gas, of course an EKG to look at the rhythm, an echo, angiography via a cardiac cath to look at the vessels of the heart. Caregiver education for a child that does have a cardiovascular disorder, and this is a little bit vague here on this slide, but they may have limitations in their physical activity. They just may not have the endurance to do certain things. They are probably going to have very frequent follow-up. Common for some of the disorders we're going to talk about is endocarditis prevention prior to procedures. So this is basically antibiotic prophylaxis. So we can prevent any sort of bacteria from getting to the heart. It's a little more common, or children can be more susceptible to it if they have certain cardiac disorders. So say if a child is going for any sort of procedure, and it could even be something as simple as going to the dentist, they may need to take an antibiotic before that. They may be at higher risk if they are taking birth control as an adolescent, and we may need to provide emotional support to the child and family. So the first types of heart disease that we're going to talk about are congenital heart disease with increased pulmonary blood flow. So there's 3 different disorders we're going to talk about that fall under this category: patent ductus arteriosus, atrial septal defect, and ventricular septal defect. Just an FYI, I would know which disorders fall under these different categories that we are going to be talking about. So the first disorder we're going to talk about is the patent ductus arteriosus. So a couple of slides ago, I talked about the ductus arteriosus, which is this structure right here that is connecting the aorta to the pulmonary artery. So this is normal in fetal circulation and for fetal development. However, we call it a patent ductus arteriosus, or a PDA for short, after it stays open longer than we would expect. So patent means basically like open and unobstructed. So normally this little pathway is going to start to close within a few hours to days after birth. So it's slowly going to get smaller until it's all the way gone. So as it starts to get smaller, this is one of the reasons why we may hear a heart murmur in a baby that is just born or maybe a few hours old, a few days old. That's because of this turbulent blood flow that is caused by the ductus arteriosus closing. If this stays open longer than we would expect, we can start to have some problems in the baby. So if we continue to have blood flowing through the aorta and then back into the pulmonary artery, it's going to create basically a backflow of blood into this pulmonary circulation. So this right side of the heart, including the right ventricle and pulmonary artery, is sometimes also called pulmonary circulation, whereas the left side, the left atrium, left ventricle, and aorta is sometimes called the systemic circulation. So we have blood going up here through the aorta on its way to the body, but then we still have this PDA here and blood is backflowing back into the pulmonary circulation. So this is what's sometimes called left to right shunting, and the left to right basically means sides of the heart. So the blood is going from the left side of the heart, shunting back to the right side. So this can cause some problems, an increased pulmonary blood flow and pulmonary edema. So if we have all this extra blood backflowing into this pulmonary artery, it's going to backflow into here, but then it's going to turn around and go to the lungs. So we're going to have basically too much blood, too much fluid going to the lungs. So on assessment, again, we could hear a systolic murmur since this PDA is still open. If it's closed a little bit, that's where we may hear a murmur. Now, if it's still just wide open, we may not hear it. Since this is going to cause that increased pulmonary blood flow and pulmonary edema, we're going to see some certain symptoms. So things like crackles in the lungs, tachypnea, and increased work of breathing. Here we're talking about babies, so poor feeding, poor weight gain. They're going to become very fatigued when they're doing things like feeding. They can actually start sweating when they're feeding, and they can have excessive fluid weight gain. They may also have bounding pulses, a longer than normal cap refill. Their heart may appear enlarged on an x-ray. They could start desatting and have a wide pulse pressure. So there are some interventions that we can do for this. So PDA is more common in premature infants. So the more premature an infant is, the higher likelihood that they will have a PDA or their ductus arteriosus will stay open. So again, they're already premature. They already may be on, say, oxygen or other support measures. And then they also have this PDA, which is also working against them. So we want to try to close it. So we can try to close it with certain medications. So certain medications like indomethacin, ibuprofen, or acetaminophen can be used to actually close the PDA. So we're usually giving these medications about every 6 hours. They can be either oral or IV medications. So the first disorder we're Another defect is an atrial septal defect, or also called an ASD for short. So this one, we have a hole in the heart right here between the two atria. So it's basically exactly what it sounds like. It's a defect in the septum between the atria. Not to be confused with the foramen ovale. The foramen ovale is more of like a flap of tissue that is open. This is sort of like the whole septum or the whole muscle is missing here. So what happens here is sort of similar to what happens in a PDA, it's just in a different location. So we have this hole in the heart, which is going to allow basically mixing of blood. So the pressure in the left side of our heart over here is typically going to be higher because the muscle's bigger and we need all this pressure to push all the blood out to the body. So since the pressure is higher over here, the blood is going to want to do a left to right shunt here also. So the blood's going to want to come from the left side to the right side because of pressure. This is similar to a PDA as it's causing this back leak of blood from the systemic circulation to the pulmonary circulation. This is going to cause a lot of load on the right side of the heart. So the right side of the heart is going to have all this extra blood coming into it, and it's going to cause a higher load and an increased chance of pulmonary hypertension, and basically right ventricular hypertrophy, which we don't want. So this is going to be diagnosed via an echocardiogram, so something that's going to be fairly easy to see on that. Assessment-wise, we can also hear a murmur because of the turbulent blood flow that's flowing in between the atria. There can be a chance of a higher incidence of emboli. So as the person gets older, if this is unrepaired, they may be on some blood thinners. They may be short of breath. They may tire easily. They may be a poor feeder and have poor growth, and have enlargement of both the right atria and the right ventricle. Some interventions for this, the baby could be prescribed digoxin or diuretics to help decrease all of that load on the right side of the heart. We also want to continue to monitor for signs of CHF, so signs like crackles and things like that, what we just talked about on the last slide, where there's too much fluid in the pulmonary circulation. Other interventions, more intense sort of interventions, is a surgical closure via cardiac cath, where they can basically come up during the cardiac cath and close this off surgically. This is one of the defects where the child may be on the endocarditis prevention prior to any procedures. Things like going to the dentist, they may be taking amoxicillin, for example, to prevent any infection. Ventricular septal defect, or VSD, is the most common congenital heart defect. It's very similar to the ASD, it's just in a different location. So instead of a hole between the atria, we have a hole here between the ventricles. It doesn't necessarily have to be one hole. It can actually be several small holes in the septum. It can be a very, very small one or a very, very large one. So basically the degree of symptoms that the person may experience sort of depends on how large the VSD is. A lot of the very tiny ones just spontaneously close on their own. But this one, similar to the ASD, results in increased pulmonary blood flow, because just like the ASD, we have the blood in the left side of the heart that's going to go over the defect and onto the right side. So we're basically going to have the same symptoms. It's going to be also diagnosed via echo. So assessment-wise, this one could be asymptomatic, especially if it is very small, but they could have a murmur, shortness of breath, feeding difficulties. They could have a systolic thrill, which is basically where you can feel a vibration if your hand was on their chest. They could have failure to thrive and recurrent respiratory infections. So interventions for this is a surgical sternotomy, which basically means that instead of going in via a cardiac catheterization, they're actually going to basically cut through the sternum to get through the heart to patch or suture the VSD closed. So everything about this is very similar to an ASD, it's just in a different location. The next category of defects is congenital heart disease with decreased pulmonary blood flow. So the last three we just talked about was increased pulmonary blood flow. These three are decreased pulmonary blood flow. So the three we're going to talk about are tetralogy of Fallot, tricuspid atresia, and Eisenmenger syndrome. The next disorder we are going to talk about is tetralogy of Fallot. So tetralogy of Fallot can be described as a cyanotic heart defect. So what this means is that the patient will show actual cyanosis. The other ones we've talked about so far, the baby or child or whoever has the disorder usually isn't cyanotic, or at least not severely, but as you can already see if you're looking at this picture, this baby is pretty cyanotic. So with tetralogy of Fallot, with this disorder, we have right to left shunting. And the previous ones that we talked about, we had left to right shunting. So what this means is it's exactly the opposite of what we talked about before. So what happens is we're actually recirculating venous blood to the body without it being oxygenated in the lungs first. So basically, blood is going from the right side of the heart to the left side of the heart. This disorder is associated with a couple of different syndromes, especially Down syndrome and DeGeorge syndrome, which is another syndrome we haven't talked about and you don't need to necessarily know about. So tetra or tetralogy means four. So to have this disorder, there's four different defects that need to come into play. So the first one is the VSD, which we already talked about. The next one is an obstructive right ventricular outflow problem. So what we're talking about there is that there's something wrong with the pulmonary artery, whether it's stenotic and narrowed, or it could be the pulmonary valve. It could be stenotic or not working properly. So what happens here is we want blood, obviously, to come up here and go to the lungs, but in very severe versions of this, it could be almost, if not completely blocked. So obviously, if a baby is born that way, then they're not going to have any blood flow going to their lungs, or a very, very small amount. They're not going to be able to breathe on their own. The third thing is an overriding aorta. It's a little hard to visualize it in this diagram, but what an overriding aorta just means is that it is connected to both ventricles. So basically down here, both ventricles are connected to the aorta. So we're basically getting deoxygenated blood that is going to the body. So since we have deoxygenated blood that's mixing and going to the body, that's why we get the cyanosis with this disorder. Also, we can have right ventricular hypertrophy due to the restricted outflow here. So since blood is having trouble going up through the pulmonary artery for whatever reason, we're going to have a lot of back pressure here that's going to cause this muscle to get bigger. So assessment-wise, one of the things that can happen is called a TET spell. So a TET spell is basically what's pictured in this baby here. Sudden cyanosis and possible syncope. So especially if it's an older child, they could actually pass out or faint. But for a baby, usually they're severely cyanotic like this, like circumoral cyanosis, can also be cyanotic like in their hands and feet. A lot of times this happens with crying or irritability due to the lack of O2. There can also be what's called pink TET spells, or we would call a pink TET baby. Basically, their right ventricular outflow problem is not as severe. It's just basically a more mild case where the baby isn't becoming so cyanotic that you can actually see it in their face. So they always appear pink or their normal color for their ethnicity. So they can also have clubbing if they have this for a long period of time and it's not surgically corrected, poor growth, a heart murmur. So here, there's not a PDA pictured here, but for the PDA, which would be up here, we actually have to have this to be open in most circumstances for the baby to be able to live until it's surgically corrected. Now, not in every case. If it is a more mild case, they may not need it open. But when this does start to close normally, within the first few hours or days after the baby's born, cyanosis will start to increase. Pulmonary blood flow is basically dependent on this PDA, because if we have all this stenosis or atresia here, and we're not getting blood to the lungs, we need the PDA that's connected here from the aorta to get blood to the lungs. So if that completely closes off in some situations, the baby would die. There's not a picture of the x-ray here, but on a chest x-ray, the heart sort of looks like a boot. Interventions for this disorder, one of the things that we can teach parents to do, or teach a little bit older children like toddlers once they walk, is to basically squat during a TET spell. So basically, if they are able to walk and stand, this just them squatting down. If it is an infant and they cannot stand, basically it's squeezing the infant's legs up towards their chest. This improves blood flow from the legs back up to their brain and vital organs. It increases systemic vascular resistance and helps them basically overcome the spell. We can also cluster their care to allow for rest. So basically letting them sleep for long periods of time and then getting in to do the things that we need to do all at once. They're probably going to be on very high calorie feeds. We're going to monitor their growth and development. They're going to have long-term cardiac follow-up. We also want to decrease agitation and prevent them from crying. So they can have these TET spells when they are agitated and crying. So the baby may be sedated in order to decrease this from happening. They're probably going to be on oxygen to reduce pulmonary vasoconstriction. So you may be wondering, when I was talking about keeping the PDA open, how do we keep it open? So there is a medication called prostaglandin E. So we can give that to the baby via IV to keep the PDA open. So basically, the prostaglandin E is a very potent vasodilator of smooth muscle tissue. So it keeps the PDA open. We have to have it going the entire time. It's one of these medications that it's constantly going through an infusion. You cannot let the bag or the syringe run out because while you're waiting for pharmacy to make you a new one, the PDA could totally close. There are some pretty severe side effects from prostaglandin E, including apnea, respiratory depression, and bradycardia. So usually the infant does have to be intubated and mechanically ventilated to have this infusion going. So usually we're going to have the prostaglandin E hooked up. We also call that PGE for short, if you see that anywhere. So we're going to have that hooked up to the baby until they are ready to go to surgery. So they have the possibility of multiple cardiac surgeries. So they may just have one to start off with to correct their pulmonary atresia or stenosis so that they don't have to have the PGE anymore. And then they may go back later to correct some of these other ones like the VSD. It just depends on a case-to-case basis, but they are probably going to need several cardiac surgeries and procedures and very long-term follow-up. Tricuspid atresia. So in tricuspid atresia, the tricuspid valve is either missing or defective in some way, so that it's blocking blood flow from going from the right atrium to the right ventricle. So if this happens, we're going to have diminished blood flow up to the lungs because there is no way for the blood to get to the right ventricle except for a couple of exceptions and roundabout ways it can get there. So if this happens, in this case, we can have blood shunted across the PFO, which isn't really pictured here. Also, sometimes when a child has tricuspid atresia, they also have an ASD or a VSD, which is actually helpful in their situation. So blood can be shunted across the ASD, and then if they also have a VSD, it can go across the VSD and then go up to the pulmonary artery. Also, we have the PDA that's going to be there too, where we can still get blood to the lungs this way. this can be diagnosed via an echocardiogram, a cardiac cath, or possibly sometimes on chest x-ray. So symptoms that a child could have if they had tricuspid atresia, they could be cyanotic because basically enough blood isn't getting to the lungs to be oxygenated. And if they have a VSD or some of these other defects, we have mixing that's going to the body. They could also be short of breath, have a murmur, have delayed growth, and clubbing. This is also sometimes associated with pulmonary stenosis, which is what we talked about on the last slide with tetralogy of Fallot, where sometimes this pulmonary artery can be stenotic, basically not formed properly, too narrow. So interventions, this child can also have PGE to keep this PDA open so that we are ensuring that we are getting blood to the lungs. They can also have surgery, a balloon septostomy, and a series of cardiac surgeries. So basically, they put a balloon up through a cardiac catheterization, and basically the balloon will create the tricuspid valve. They could have a possible heart transplant if it is extremely severe and cannot be corrected in other ways. They're going to have lifelong cardiology care. We want to monitor for signs of fluid retention, shortness of breath, cyanosis, slow growth, and a fast heart rate. Eisenmenger syndrome. So Eisenmenger syndrome is a syndrome that can occur with older children or even adults when they have an untreated PDA, VSD, or ASD. So the example here, this person has a VSD, so we'll talk about that. So originally, or I guess maybe at birth and when the child is young, we have this left to right shunting with this VSD. So like I said before, because the pressure in the left ventricle is going to be normally higher than the pressure in the right ventricle, the blood is going to want to flow from the left side to the right side because of the pressure. So basically, this is untreated in this child. Maybe they don't know they have it. The child gets older and older. Maybe they're an older child or even an adult now. So over time, this right ventricle, the pressure builds up and builds up and builds up over time because of all of the blood going into it. So there's a high pulmonary vascular resistance here. So there's a larger pressure now in the right side of the heart than the left side of the heart after this being untreated for so long. So when this happens, we are going to have less blood that's going up to the lungs and more unoxygenated blood going over to the left side of the heart and then to the body. So what this is going to cause is the person to be short of breath because they're not getting enough blood to their lungs. They're going to be fatigued because they're not getting enough oxygenated blood to their body. They could actually have chest pain. They can have cyanosis. And the body is going to think that they don't have enough RBCs because they're not getting enough oxygen to their tissues. And we can have some of these compensatory mechanisms, like the bone marrow is going to be signaled to make more RBCs. This can then lead to some of these other problems down here. Interventions for this, they are probably going to need hypertensive meds. We're going to have to very closely monitor their blood pressure because it can quickly go out of control. This is not an exceptionally common syndrome. Most of the time, if people have a PDA, a VSD, or an ASD that is severe or bad, they're going to already have treatment for it because they're going to already have so many symptoms. But if this is untreated, this could develop, and we could have to prepare for ECMO. So ECMO is extracorporeal membrane oxygenation. So basically it's heart-lung bypass. So only certain facilities do this, especially with children. So you may have to prepare for transfer. So this person could need intensive cardiac surgery or even a heart transplant. The next category of disorders we're going to talk about are congenital heart disease with obstructive disorders. So the ones we're going to talk about are coarctation of the aorta, aortic stenosis, pulmonary stenosis, and pulmonary atresia. Sometimes we can also put tetralogy of Fallot in this category because it does have that right ventricular outflow obstruction, but for this text, it was going to be in the previous section. Coarctation of the aorta. So what coarctation of the aorta is a narrowing of the aorta between the upper body and the lower extremities. If you're looking at this drawing on the top, on the right-hand side where there's the picture of the aorta, you can see that the aorta, where it starts to basically turn and go down, at least in this picture, is where it's very, very narrowed, almost totally occluded. It doesn't have to be exactly in that spot, but that's a very common spot for it to happen. This is associated with VSDs and also Turner syndrome. So assessment-wise, if we know that the child has coarctation of the aorta, they almost always have 4-point BPs ordered because of these symptoms. So the patient usually has an increased blood pressure in their upper extremities and a decreased blood pressure in their lower extremities. It's a greater than 20 millimeters of mercury difference than their upper extremity blood pressure. If it is on the mild side, so say it's not as severe looking as this diagram here, maybe the narrowing isn't that bad, they may have very few symptoms. They can also have decreased or weak femoral pulses, or basically any pulses on the lower half of their body. They can have cardiomegaly, right-sided heart failure, headache, hypertension, shortness of breath, poor feeding and growth, and basically signs and symptoms that go along with congestive heart failure. If we have a chest x-ray, sometimes it will show this 3 sign, which is what the x-ray on the slide is showing, or an E sign, which is basically where it's just flipped. Again, you don't have to be able to identify x-rays on the test or anything like that, just something to know. Interventions, so we can have balloon dilation, where basically they put a balloon through one of the femoral arteries going up to the heart at cardiac catheterization, and basically inflate a balloon to help increase how narrow the aorta is. They can also place a stent in at that time to keep the aorta open. Sometimes they have to do a graft from a cadaver. We have to monitor for congestive heart failure, so we may be, of course, monitoring their blood pressure and INO, and they may be on medications such as digoxin and Lasix. These patients are also going to have the bacterial endocarditis prevention, where they're taking amoxicillin or whatever is prescribed before a procedure. They may need to restrict strenuous activity depending on how severe their symptoms are. Aortic stenosis. So what aortic stenosis is there's some sort of obstruction of blood flow coming from the left ventricle into the aorta. So this can be caused by valve stenosis. So the aortic valve here can be stenotic, which means it can be narrowed. It's basically just not functioning properly. It could also just be the lower part of the aorta here is also stenotic. So sort of like where these arrows are pointing to, could be have narrowing there. One of the causes of this, or the possible causes, can be from strep throat, causing rheumatic fever, which can then scar the aortic valve. Assessment-wise, the patients may have fatigue, chest pain, syncope. They may have a murmur, depending on how severe the stenosis is, causing turbulent blood flow. They can have shortness of breath, a narrow pulse pressure, and exercise intolerance. So one of the interventions, depending on how severe the narrowing is we could be using the prostaglandin E to keep the PDA open until surgery. So the PDA isn't shown on this graphic, but it would be right here. And in most instances, we want to keep the PDA open to keep blood flowing from the aorta to the pulmonary artery here, but it can actually flow the other way if needed to get blood into the aorta if there's no other way. So if you picture this aortic stenosis being so severe that little to no blood is passing to the aorta, obviously a person cannot live that way. So we would need to keep the PDA open to allow some blood to backflow from the pulmonary artery into the aorta. They can also have a balloon valvuloplasty, which is basically via cardiac catheterization. They would bring a balloon device up here to repair the valve. We want to monitor for signs of CHF, and this patient would also be on bacterial endocarditis prevention. So we have pulmonary atresia and pulmonary stenosis on the same slide here because they are a little similar, one just a little worse than another. Pulmonary atresia, or on here it's PA for short, is where the pulmonary artery or the pulmonary valve does not form properly. So here it's a little confusing on this graphic, but if you can picture either the pulmonary valve not being there or being malformed, or even the entire pulmonary artery not being there or not formed properly. So basically, we're not having any blood that's able to go to the lungs in a normal fashion. With pulmonary stenosis, or down here it says PVS for pulmonary valve stenosis, there is a narrowing in the opening of the pulmonary valve or artery. So as you can see in this picture, the valve looks like it's a little bit narrowed. This one is associated with Noonan syndrome or tetralogy of Fallot. You don't need to know what Noonan syndrome is. It's just another syndrome that has cardiac defects and other facial characteristics associated with it. So for these, the pulmonary atresia is a little bit more severe than pulmonary stenosis. Assessment-wise for pulmonary atresia, the patient is going to have shortness of breath, severe cyanosis at birth. If you can picture blood not being able to go to the lungs normally, so we're not going to have oxygenated blood going to the body. Fatigue, tachypnea, poor feeding and weight gain, and a murmur. For pulmonary stenosis, or down here, pulmonary valve stenosis, you could call it either, murmur, shortness of breath, cyanosis, and congestive heart failure symptoms. Interventions for pulmonary atresia, we need to have PGE to keep the PDA open. So in this graphic, they do have the PDA actually drawn in there. So we are going to have that PDA open for any blood to get to the lungs because the pulmonary artery or the pulmonary valve is either not there or severely deformed. They can also have a balloon septostomy to keep the PFO open. So basically via cardiac cath, they could come in here and keep this PFO open so that it doesn't close. Other cardiac surgeries and possibly a heart transplant depending on how severe the atresia is. Interventions for the pulmonary stenosis, they could have balloon angioplasty or valvuloplasty. So usually via cardiac catheterization, coming in and inflating a balloon here to fix the valve. The next category of heart defects we're going to talk about is congenital heart disease with mixed disorders. So what mixed disorders basically means is that blood from the systemic and pulmonary circulation is mixing in the different heart chambers, which is going to cause desaturation and decreased cardiac output. So we're going to talk about transposition of the great vessels, truncus arteriosus, and hypoplastic left heart. The next disorder we're going to talk about is transposition of the great vessels. So transposition of the great vessels basically means that the aorta and the pulmonary artery are reversed. So in this terminology, the great vessels are the aorta and the pulmonary artery. So literally, they are switched in their position and what they are connected to. So as you can see on this graphic here, the right ventricle is connected to the aorta instead of the pulmonary artery, and the left ventricle is connected to the pulmonary artery instead of the aorta. So we have non-oxygenated blood, or at least mixed oxygenation blood, flowing to the brain, which can cause brain damage and other neurological damage. So picture here, the aorta is going to the body, but we have this, in this instance, mixed blood flowing up to the brain and to other areas of the body instead of oxygenated blood. We also have blood coming back from the lungs that is oxygenated, but then again, it becomes mixed, and then we are eventually sending blood back to the lungs that's mixed and already is at least partially oxygenated. So the infant is dependent on some sort of extra pathway to survive. So we need to keep the PDA open, or if they already have a VSD or an ASD, they have to have one of these things in order to survive because they're basically dependent on the mixing of the blood to survive. Otherwise, they would have completely unoxygenated blood going to the brain and the body. Assessment-wise, this is a cardiac emergency. It usually presents at birth or within 24 hours of birth. We usually do, if you guys may have seen, probably in your OB rotations, doing the congenital heart disease screening on infants before they're discharged, putting it on their right wrist, the pulse ox, seeing if it's basically lower than, say, their feet. So one of the symptoms of this is their upper extremities have a decreased O2 saturation versus their lower extremities, especially the right arm. So this is one of the reasons why we do that congenital heart disease screening with the pulse ox. The baby is going to have profound severe cyanosis, especially if they are crying or trying to feed. They're going to have tachypnea, a murmur, signs of congestive heart failure. On X-ray, the X-ray can look like it's described as an egg on a string, as you can see in this X-ray down here. They have sort of a drawing of an egg on a string, kind of a little bit far-fetched, but you can see that in this little infant's body, at least on this left-hand side, this heart looks gigantic in this baby's chest. Interventions, so we need to keep the PDA open if they do not have a VSD or an ASD. So they will be on prostaglandin E to keep the PDA open to allow some mixing. Because although, of course, we want oxygenated blood going to the body, at the very least, we want mixed blood going to the body. They can also have an atrial septostomy to basically make a ASD. So basically making a hole if they don't already have one. And then they are eventually, of course, going to have surgery to switch the arteries. So it's called a J-tein arterial switch. You don't necessarily need to know that, but they're literally going to have to go in and switch these great vessels back to the way that they go. Truncus arteriosus. So truncus arteriosus is where we basically have one single great artery or great vessel that is coming from both the left and the right ventricle of the heart. So instead of having a separate aorta and a separate pulmonary artery here, it's just one giant vessel. Usually also the valve here, which they usually just call a truncal valve, is stenotic or incomplete, so it's not working properly. There is an increased incidence of this disorder from babies that were born to mothers with certain viral infections, such as German measles, also babies with DiGeorge syndrome, Down syndrome, infants of diabetic mothers, and mothers who drank excessive alcohol during pregnancy. So assessment-wise, since basically we have mixed blood going to the brain, the baby is going to present with cyanosis and tachypnea. They could be sweaty. They could have pulmonary congestion from excessive blood flow going to the lungs. So congestive heart failure type symptoms, wheezing, grunting, retractions, difficulty feeding, and a loud murmur. So intervention-wise, we want to try to avoid supplemental O2 if possible. It can actually lead to even more pulmonary blood flow, which we don't want, even more because they already have too much pulmonary blood flow. I have taken care of a baby before that actually had this and was not on oxygen, surprisingly. But they may need oxygen and they may need mechanical ventilation if necessary. Kind of depends on how severe it is and when it is diagnosed. But they're obviously going to need a complex surgical repair here to make two different vessels instead of this one. So I don't think I mentioned this at the beginning, but they do have this overriding VSD that goes along with this. So basically all of the blood from the two ventricles can mix so that there is partially oxygenated blood going to the body. Hypoplastic left heart syndrome is where we have an underdevelopment of the entire left side of the heart. So we have underdevelopment of the aorta. As you can see in this graphic, this is a very skinny, tiny aorta. The aortic valve, the left ventricle, and the mitral valve. So all of those things are usually underdeveloped in some way. As you can see on here, this is a tiny little left ventricle compared to this right ventricle over here, which is huge, usually sort of flip-flop the other way around. So this can lead to pulmonary venous congestion and edema. So basically you can see this right ventricle is really big here and we have a ton of blood that's going to the lungs, which can cause sort of like CHF type symptoms. These symptoms may not start to appear until this PDA closes. So we need this PDA open in order to get adequate blood to the aorta. So blood that's mixed is coming up this pulmonary artery and then is going into the aorta down to the body. Since over here, this little skinny part of the aorta may not be functioning properly, or it's so narrow that a whole lot of blood isn't getting through. So as you can see here, this PDA looks giant compared to the aorta, and we need to keep that PDA open. So symptoms may start to appear when the PDA starts to close, depending on the severity of the disease. This syndrome is also associated with absence of the corpus callosum. The corpus callosum is basically the structure in your brain that connects the two hemispheres. You can live without it, but sometimes people can have things like learning disabilities and things like that. But sometimes they may live their whole life and not know. Assessment-wise, the child may have ashen or a dusky skin color. It could also be cyanotic. We could hear a gallop when we're listening to their heart. They could have tachypnea, shortness of breath, difficulty feeding. It is going to be fatal within the first days or months of life unless it is treated. So like I said, we need to keep the PDA open. So they are going to be on PGE or prostaglandin E. They are going to have surgery. It's usually at least a 3-stage surgical procedure to correct it. They could possibly need a heart transplant, especially if their left ventricle is very, very small. They're going to need long-term cardiac care and medications, and they're also going to be on the bacterial endocarditis protocol before procedures. The last category of heart diseases we're going to talk about are acquired congenital heart diseases and also shock. So we're going to talk about rheumatic heart disease, Kawasaki disease, and congestive heart failure, along with shock. Rheumatic heart disease. So rheumatic heart disease is a systemic inflammatory disease that occurs in response to group A beta hemolytic streptococcal infection. So usually strep throat or scarlet fever. So if the patient doesn't get treatment for their strep throat, maybe it's only partially treated or it just doesn't necessarily kill all of the bacteria, the infection can spread into the bloodstream. Usually about 20 days after the onset of the strep throat. And if it remains untreated, it can lead basically to bacterial clumps that can break off and travel to other organs, like the lungs, brain, kidneys, and heart. So when it travels to other organs, that's what we call rheumatic fever. You can have some of these symptoms that's listed on this chart at the bottom, like joint pain. Chorea is like jerky musculoskeletal movements, nodules under the skin, fever, a rash, raised inflammatory markers like C-reactive protein, prolonged PR interval. Eventually, over time, so usually a long period of time, like up to 15 years later, then the patient can develop rheumatic heart disease, which is basically damage to the heart valves and also the joints. There is a genetic component where it may run in families. And interestingly, it often occurs in low socioeconomic um, situations and in the Northeast United States. Assessment-wise, the client could have abdominal pain, nosebleeds, chest pain, palpitations, paroxysmal nocturnal dyspnea, which is basically shortness of breath that's waking them up at night, a non-pruritic rash, a fever, heart block, and subcutaneous nodules. So if a child is diagnosed with rheumatic fever, they're going to need cardiac follow-up for some time. Things like echocardiograms to check to see, are they developing rheumatic heart disease? So we're going to be doing cardiac assessments on them if they're hospitalized with rheumatic fever, and then over time, outpatient follow-up. If they do get diagnosed with rheumatic heart disease, then they can be on anti-inflammatory medications and also antibiotics if they do have any lingering infection. They could need heart valve repair if they do have mitral stenosis, aortic stenosis, or severe regurgitations. And they could be on prophylactic endocarditis treatment to prevent any sort of infection. Kawasaki disease is the leading cause of acquired heart disease in children in the developed world. It's a multi-system disease that affects the cardiovascular system and is actually one of the only instances that can lead to a heart attack in children. So the disease isn't contagious, it's not congenital. It's thought to be caused by an infective organism seen seasonally in certain locations, a higher incidence in the winter. It can cause death if the child does develop an MI or have severe cardiac scarring and stenosis. It can also mimic other diseases and be confused with measles and scarlet fever. So it could be misdiagnosed, which you'll see why when we talk about the symptoms. It is more common in children under 5, boys, and Asian or Pacific Island descent. Assessment-wise, the child will have a high fever and then 4 of the following 5 symptoms. So a rash on the trunk and or genitals, enlarged lymph nodes in the neck, conjunctivitis, red lips and a strawberry tongue, and then red swollen hands and feet that peel. So all those things are a little bit similar to some severe strep throat or scarlet fever. They can also have diarrhea, abdominal pain, joint pain, irritability, and like I said, they may develop a coronary artery aneurysm leading to an MI, which actually occurs in 73% of children within 1 year. So interventions for this, they're going to be on anti-inflammatory meds, usually high-dose aspirin. So one of the only instances where that we are actually giving them aspirin. And this is going to be like antiplatelet therapy to decrease the risk of the coronary artery aneurysm. So they're usually going to be on that for like 6 to 8 weeks at least. We can also give them IVIG or IV gamma globulin. Again, it's going to decrease the risk of the coronary artery aneurysm. We're going to monitor them closely for congestive heart failure symptoms. Nursing care, if they are admitted, besides giving them these medications, some other things we can do is make sure that they're wearing loose clothing because of the rash. We can apply cool cloths to their lips and their eyes because of the symptoms there. Other mouth care because of the strawberry tongue, so like soft touffettes, keeping their mouth moist. Soft, tepid foods and drinks. And for the parents, they should get CPR training for children. So basically, once they're discharged, the parents should be ready in case the child does have an MI, that they can at least start CPR before paramedics get there. This child is going to need long-term congestive heart failure. So you've learned about congestive heart failure before, and I've already mentioned it 100 times in this lecture. But with CHF, the heart cannot supply enough oxygenated blood to meet the metabolic needs of the body tissues, either at rest or at work. So it can be basically a complication of all or most of these things that I've talked about before. So from a bunch of these congenital defects that we've talked about, like coarctation of the aorta, aortic stenosis, valvular regurgitation, cardiomyopathy. So CHF in pediatric clients with a congenital heart disease usually depends on whether the child does have a ductal dependent lesion, which will most likely present with cyanosis at birth or in the newborn period as the ducts begin to close. So when I say ductal dependent, that's any of the ones where I said we need to use PGE to keep the PDA open. So right-sided heart failure is where the right ventricle cannot pump blood into the pulmonary artery for whatever reason. It's going to result in an increased pressure in the right atrium and the systemic venous system. So basically things are backing up in the systemic venous system. And then left-sided heart failure, blood is backed up into the left atrium and the pulmonary veins, resulting in increased lung congestion. We can have a bunch of different signs and symptoms of congestive heart failure: edema of the face, hands, feet, weight gain, cardiac enlargement. You could hear a gallop on auscultation, tachycardia, tachypnea, sweating, higher blood pressure in the arms than legs, shortness of breath, cyanosis, crackles, fatigue, poor growth. Interventions, if they do have a congenital defect, then of course surgery or cardiac catheterization procedure to correct it. Elevating the head of the bed and giving them supplemental O2 if needed. Monitoring their intake and output, daily weights, listening to their breath sounds to see if we hear things like crackles. Clustering their care to allow periods for rest. High calorie feeds. They could be on medications like digoxin, diuretics, inotropic agents to maximize cardiac output and eliminate any excessive fluid. So the last thing we're going to talk about is shock. So shock is the inability of the body to maintain adequate blood flow and oxygen supply to the tissues needed for metabolism. So shock is one of the leading causes of childhood morbidity and mortality in the world. Sometimes the underlying cause can be difficult to diagnose. Sometimes, though, it's fairly obvious. So we're going to talk about 3 different types. Yes, there are a couple other different types, but we're not going to talk about them for the cardiac lecture. So hypovolemic shock, basically low volume caused by dehydration or loss of blood with a decrease in hemoglobin. Cardiogenic shock is going to be damage to the heart muscle that results in failure of the heart to pump properly. And then septic, or also sometimes called distributive shock, is where fluids shift from the intravascular space to the extracellular space caused by blood vessel dilation, often due to overwhelming infection and sepsis. Assessment-wise, you could have a bunch of different symptoms. These are all just kind of clumped together, but they could have altered level of consciousness, a sudden rapid heart rate, sweating, pallor, weak pulse, rapid breathing, decreased or absent urine output, and cool hands and feet. Interventions, so the treatment is going to be dependent on, of course, the cause and type. This is one of the only instances where we could be placing the patient in Trendelenburg to help distribute blood back to the major organs, especially like the brain. Again, depending on the cause, we could be doing care such as IV hydration, like for hypovolemic shock, blood products, different pressors, or inotropes for cardiogenic shock. They also may need oxygen supplementation.